morning, everyone. Welcome to Grand Rounds. For those who don't know me, my name is Claudia Fox. I'm our medical director of our pediatric weight management program. Today, I am super excited to introduce our speaker, Dr. Amy Gross. Dr. Gross is an assistant professor in the Department of Pediatrics. She completed her MS at North Dakota State University and her PhD at Western Michigan University. Her psychology internship was in behavioral pediatrics at the University of Nebraska Medical Center, and her postdoctoral fellowship was at Johns Hopkins University School of Medicine. Dr. Gross is board-certified behavioral analyst. Her clinical and research interests include behavioral and developmental disorders in young children, pediatric weight management, adolescent weight loss surgery, and fetal alcohol spectrum disorders. Dr. Gross is the treasurer of the Minnesota Northland Association for Behavior Analysis and is a member of the Obesity Society, Minnesota Pediatric Obesity Consortium, and the Association for Behavior Analysis. Amy is also a superb colleague and collaborator and clinician. Amy is going to talk about an innovative approach to weight management family style.
Good morning, thanks for coming. Like Claudia said, I'm going to be talking about development over the last year or so of a family weight management clinic that we're doing here at the University of Minnesota. I have no financial relationships to disclose, and obviously, though I don't prescribe them, I am going to be discussing some case examples where there is off-label use of medications for obesity. These are the objectives for today's talk, and I'm going to move right into it. So because I'm going to be talking about both kids and adults, I want to just get on the same page in terms of terminology as we're talking about overweight and obesity. So in the adult world, overweight and obesity categories are based on straight BMI. So you can see at a BMI of 25, we started an overweight category, 30 and over is obesity, and 40 and over is what's now termed severe obesity. And for children, BMI percentiles are used just due to some difficulties using straight BMI for kids. And as most of you know, above the 85th percentile for kids is considered overweight, above the 95th percentile is considered obese, and then 1.2 times the 95th percentile is the severe obese category. By way of some numbers, about 17% of kids and adolescents are obese, with that number or prevalence increasing with age. So you can see when we get to that 12 to 19-year-old category, over 20% of kids are in this category. But I do think it's pretty notable that over 8% of 2 to 5-year-olds are already carrying significant extra weight and in the obese range. I'm sure many of you have seen these maps before. Adult obesity prevalence kind of ranges by state from about 20% to over 35%. Here in Minnesota, we are in that 25 to 30% range. So what contributes to obesity? That could obviously be a talk in and of itself, but kind of thinking about models that we may use in clinic and talk with families about, we're often looking at a biopsychosocial model. So for example, thinking about some of those biological contributors, we might be looking at family history of obesity. In the psychological realm, maybe things like stress eating, emotional eating that might contribute to excess weight. In that social or environmental realm, things like unsafe neighborhoods that get in the way of engaging in physical activity, and those types of things. Using a model like this or other sort of multifactorial models is really helpful for both clinicians and the patients and families to really start to identify those different contributors, which may lead to many points of potential intervention. From that family history aspect, obesity certainly is multi-generational. For a child who has one parent who is obese, they have a 5 times increased risk of being obese themselves. And if both their parents are obese, the child has a 10 times increased risk. 10 times is a lot, so pretty high there. And of course, those things are both environmental and genetic contributions because the child and the parent share both of those things. However, when we look more towards some of the adult research and the twin studies So kind of those classic twin studies where twins are separated and looked at later in life. There's about a 40 to 75% variance in BMI that's explained by genetics. So we do really think that genetics has a pretty notable role in a person's weight. So, of course, we've been talking about these contributors to an individual. This is just basically an illustration of the biopsychosocial model times 4. So for a family of 4, just kind of how easily that gets more and more complex with those both shared and individual factors all overlapping and becoming very intertwined. For obesity, like other chronic diseases, we do need to tackle this from multiple angles, and it may take or may make sense to treat the family as a whole and to treat these multiple family members who have these both individual and shared factors contributing to their obesity together as a unit. Before we get into talking about the family-based intervention, I do want to go through current recommendations for pediatrics and adults because they are a bit different in how it's recommended we intervene on pediatric and adult overweight and obesity. For primary care pediatricians, when we're looking at kids with overweight or obesity, the recommendations, and many of you are probably familiar with this, are to go through a tiered approach. For a child with overweight or obesity, the first tier of that approach is considered Prevention Plus, which is done in the primary care office. And these are a lot of the same prevention messages that are given to kids who do not carry excess weight. So like 5210 messages, which is basically 5 fruits and vegetables a day, less than 2 hours of screen time, an hour of physical activity, no sugar sweetened beverages. Those type of recommendations are kind of re-reviewed and an increase in encouraging the family to support those recommendations. But the difference in Prevention Plus, so to speak, from the typical prevention recommendations is that at this point the recommendation is for the child to lose weight rather than maintain their weight. If a family is struggling at that level, then they move to the next level of structured weight management. This is typically still in a primary care office, or the thought is that it could still be in a primary care office, but with people who specialize potentially in obesity management, and the inclusion of, for sure, a dietitian. So similar messaging, but maybe a little bit more structured meal planning and more regular follow-ups on the order of monthly. Moving up in intensity, there's a pretty big shift in intensity here, moving to like the third tier in terms of the comprehensive multidisciplinary intervention. These are interventions that increase quite a bit in terms of frequency. The multidisciplinary team gets even broader with registered dietitians, physical therapists, behavioral specialists, physicians or other providers who definitely are monitoring that overall medical aspect for the child. And these are typically, like I said, out of the primary care realm, so to speak. Fairly prescriptive and detailed behavioral recommendations with the goal of a negative energy balance. So again, really working toward that weight loss piece. And then finally, moving up to tertiary care, this is really reserved in the pediatric world for kids with severe obesity or obesity with significant comorbidities. And the idea, in theory, is that people have moved through all of these tiers before they get to tertiary care. Tertiary care is where, as you know, there are kind of more intense interventions added on to those behavioral recommendations. So this is where we start to consider things like medication management, or more aggressive dietary recommendations in terms of very low-calorie diets, and sometimes bariatric surgery, depending on the patients. These differ quite a bit for adults. Adult recommendations are much more aggressive in nature, I would say, in terms of that if an adult carries excess weight and they're in either the overweight or obese category, their readiness is assessed, and if they're ready and want to move toward intervention, they can go ahead and do that and move to what would be considered tertiary care for kids. So move right to things like more aggressive dietary recommendations, medications, and the standards are a little bit lower for getting to the point of bariatric surgery. I think a nice similarity across the recommendations and the models is that obesity is appropriately considered a chronic disease that is going to require that long-term care and intervention over the course of one's life. So as you might imagine, there really aren't recommendations for treating a family together for obesity. So we just kind of pull from broad best practices. I do want to give you some context to how and where the idea of this family clinic got started. So as a team over the last several years, different providers and people have been talking about how this seems like it could be something that's fairly helpful to have multiple family members treated together, because we do know that obesity seems to run in families. And actually Claudia and then Shalimar Sibley, who's an adult weight management physician, happened to have clinic days that were the same out in Maple Grove. And some of Claudia's patients' parents were really expressing an interest in addressing their own weight management. I think a couple were post-bariatric surgery patients and had experienced a little bit of weight regain and things like that, and were really interested in getting back into some medical weight management to support their health. So Claudia reached out to Shalimar, and they kind of started a trial run with a couple patients using the dietitian out in Maple Grove, and saw these patients together. So that was kind of our first stab at least trying out this model. And it seemed to be something that the families attended, appreciated, and seemed to be getting some momentum. So we felt like, okay, this really could be a go. And so then over the course of the next few months, did a little bit more planning, and then officially launched our first official family weight management clinic last April, so in April of 2015. And we've had, this is a one half day a month clinic. So it has been running for over a year, but it's a half day a month. So we're still in early phases, certainly. There really aren't other clinics like this that we are aware of. There are certainly some family-based intervention programs, so multidisciplinary intervention programs, but they're just a little bit different in nature. So they tend to be more time limited. So you may have really regular sessions for 6 or 8 weeks, but the whole program is maybe 2 to 6 months, and then there's kind of an end point. So it doesn't have that chronic disease model, really. It's kind of a, you might think of it as almost like a commercial program, but a little more grounded in research and things like that, but it has a start and an end point. So there just isn't really that chronic care model. And those programs tend to be truly focused on the kid, and even when they are family-based, it's kind of bringing parents in to support the overall goals of the kid with some directed toward the parents. But it's really, the feel is that they're more directed for the kids and pulling the family in to support the kids' weight management. And for us, it was really important to truly be treating all members of the family and having both the adult and pediatric providers, so that everybody truly had kind of their own treatment planned, as well as their shared and unique, their shared treatment goals. So just because multiple family members carry excess weight does not necessarily mean that our idea is actually a good one, right? So there is some convenience of all being seen at the same time, but we really think that this is more than convenience. It's more than kind of one-stop shopping, that there is literature to support that this would be a good idea, and then we're going to talk about some case examples as well. So for the remainder of the presentation, I'm going to go through kind of literature and then case examples of how we're seeing this play out in our clinic. So we'll start with family systems theories, as well as a little caveat on sort of blame and shame of an individual patient. So theoretically, based on family systems, this would be a great idea. Okay, family systems theories, there are actually many family systems theories, but one of the common threads among the family systems theory is that a family is in fact a system, and that changing one piece of a system, like any system, kind of throws that system out of whack, and the system will work to maintain balance and maintain homeostasis, right? So it's just like any other system. If you change one piece of a family, the other family members get uncomfortable and they don't like that, and they kind of work toward getting it back to the way it's always been. So if we're trying to make goals for one individual kiddo, or for Shalimar making a goal with a parent, that throws the family off, right? So if one person is changing their meal approach or their shopping approach or something like that, the rest of the family doesn't get that, and they're not on board, and so they kind of work against that change, so to speak. So the more family members or the more pieces of a system that you get on board with the change, theoretically, the better that change works. Of course, that's all theoretical. One of the sort of fun case examples to start with is a family where we've actually seen all members of the family over the course of the last year or so. So I just wanted to talk about them first in terms of this family systems idea. So initially a now teenage daughter, but when she was 12, she initially started seeing Claudia in clinic. So this was a couple years ago. And she presented with a BMI of 39. She has a mild, sort of unspecified neurodevelopmental delay. She has a low metabolism, and kind of through that, her treatment plan has been a structured meal replacement plan and a combination medication regimen. And so they had been working for a while, like I said, with Claudia. When the Family Weight Management Clinic started last spring, she came to clinic with her mom and her older sister. Her mom, who was in her mid-40s, came in with an initial BMI of 35 and had been told previously that she had worked in another program and had been told that she had low metabolism as well, which we found to be true. And so she actually went on a fairly strict plan where she's on a 900 calorie per day meal plan, which I can see faces, you guys get that that's really low. And so she also had a similar medication combination to support that, and fortunately was very highly motivated. So kind of through her motivation as well as the medication that helped sort of keep that hunger down a little bit, she actually was pretty successful with this plan, and over the course of a year or so has really reduced her BMI into about 30. The sister was 19 years old at initial intake. She was actually heading off to college, so she came in, she had a BMI of 36. We actually don't know where that went over time, but she kind of got started on lifestyle management, and we referred her to therapy for some identified anxious and depressed symptoms that she had that contributed to her excess weight. So then over the course of time, while the mom and sisters are being treated, the dad ends up coming in as well. And he comes in with a BMI of 41 at baseline, and he actually went with primarily, well, not primarily, he did all lifestyle management. He has not used medications to support his weight loss. He has a job that's fairly stressful, requires a lot of eating out and things like that. So a lot of the intervention has been more on trying to figure out how to make some of those changes. And he's made some nice changes as well. So his most current BMI was a 39. So like I said, certainly all families are not the successful where we get to say everybody's BMI is moving down or that everybody's involved. But this is really a nice example of how this has been helpful, and where we can see some of those similar factors with the mom and daughter who both have low metabolisms, and then some different factors. You know, the stress of dad's job really is not something that's potentially directly affecting the other kids as much. So, and that's been a pretty fun family to have in clinic. Like I said, as it relates to family systems, I want to just take a couple minutes to talk about one of the cool things about Family Weight Management Clinic is that you kind of start from a basis of that multiple people are on board, right? They're not going to come to family clinic if they're not thinking that this is kind of multiple people's issue and thing that they need to work on. And this is definitely in contrast to sometimes when I see families in our pediatric weight management clinic where there seems to be kind of the identified patient who it's sort of a problem that we have to make changes in our food because of them, and why can't we have chips and pop and those kinds of things in our house, and our other kids sort of deserve those things. And families really worry about kind of this idea that we're punishing the other members of the family by eating healthier. So this is a pretty common concern, actually. A more notable example recently is that we had a school-age kiddo and her parents who came to clinic, and her siblings do not carry excess weight, and this is often it's a little bit harder to get that rationale around nobody's really going to be hurt by not having candy and chips and pop in the household. It's not easy, but it's not harsh or mean either. This family in particular really struggled with this idea and really felt that their other kids were being punished by the changes that that they were trying to make as a family. So the fact that they couldn't buy as many sweets and treats and bring them into the household really felt like a problem. And we did our typical rationale, seemed to get them on board. Unfortunately, maybe we did not, because on follow-up we learned that when one of the other siblings got punished and lost a privilege for, example, like they didn't finish their homework and then so they didn't get access to a privilege, then all 3 kids didn't get access to the privilege because, in fact, they have to treat them all the same. And this seemed sort of in response to this idea that because they were making these food changes and punishing the other siblings with those food changes, they needed to punish all of the siblings similarly if they lost, for example, screen time. This is a little bit more extreme than most families get on this, but the undercurrent is the same for many families, that there's kind of this identified patient, it's their problem, why do we really need to kind of support those things? On the flip side, of course, it's not always perfect in family weight management either, but we recently had a family who just, the mother and daughter come in, she also has a sibling who, truly doesn't carry excess weight, doesn't struggle with weight management. But as a family, they've definitely made changes. They went on a trip with an all-inclusive resort last winter, and they made plans as a family for how they were going to manage that and how they were going to eat at these places and things like that so that they could all be on board, which then lends itself to much more comfortable conversations about, the teen kind of noting at a recent family event, did you see so-and-so just pile up her plate with all this food? How does she pile up her plate with that food? And, she doesn't have to, her sister doesn't have to carry excess weight, but she can have all that food. Well, in the context of support and mom being there, she can really kind of validate that and then gently say, yeah, I also noticed she didn't hardly eat any of the food on her plate. Her body and mind kind of lets her recognize those satiety cues and just stop, right? But that can happen a little bit more in the context of a family that's all really working together. And then they can start to really see where those differences lie and how they can kind of problem solve and work together on that. All right, moving on. We're going to talk a little bit about social support and modeling. There's a lot of literature to support that social support or modeling of particular healthy behaviors is something that promotes kids' use of those behaviors. So kids tend to mimic parents' beliefs about eating, their eating styles, their physical activity patterns. If parents promote those things, a lot of times those things can change. That relation to weight change is not necessarily as clear, but those specific behaviors, it is pretty clear that those things are helpful. When we look at social support or modeling, though, in this context, it is important to kind of think about those younger kids, adolescents, and then how that may or may not help adults. So in terms of younger kids, there are some, like I said, family-based intervention programs. Probably the closest example of what we're doing is Epstein and colleagues have been researching for the last 30 years or more a family-based intervention for weight loss. And they use the traffic light diet. They have a physical activity program. They do rewards for weight loss and compliance with goals. There's behavioral contracting, all sorts of things. If you're not familiar with the traffic light diet, basically it's a mechanism for categorizing foods that's supposed to just kind of make those choices a little bit easier. So green foods are those that are low in calories. Yellow foods, as you might imagine, are moderate in calories for the nutrition sort of gained from the food, and red are high in calories for the nutritional value. What's nice about this group is they have a lot of long-term follow-up as well. So this is some child outcomes. These are 3 groups. All groups have access to the information about diet and exercise and those types of things. The child and parent-focused group, which is in the circles, is a group where they received rewards basically both for parent and child weight loss, and then parent and child demonstration of knowledge of the strategies. Child-focused, they receive the same information. Parents and kids receive all the information, but just the rewards are based on child's goals. And then the non-specific is they receive the information, but there's no reward attached to weight loss for either or demonstration of knowledge. So you can see that everybody does well kind of with the intervention early on in the first year or so. Over time, there's some gain. Only the parent and child focus group at 5 and 10 years remain below their baseline percent overweight for the kids. The other two groups, when it was just focused on the child goals or when it was nonspecific, by 10 years end up above their baseline percent overweight. Parent data are not as positive. So the parents at a little shy of 2 years are down from their baseline percent overweight, but by 5 years are back up, and then by 10 for all groups are above their initial percent overweight. Again, that's probably a whole separate talk of why those things are different. But one thing is these are 6 to 12-year-olds at baseline, so they're still doing a lot of growth. So they do have the benefit of growing in height, and these numbers are all percent overweight, so there's changes that way that the parents maybe do not have that option. Regardless, child outcomes do show that when the parent's really involved, that's helpful, and it seems to be pretty clear across other research groups that in these younger kids in this like 12 and under range, that this parent support and modeling really is promoting of success for weight loss interventions. As we move to adolescence, it's a little bit less clear. So adolescence, as you know, is characterized by a little more independence, a little more time with peers, and some separation from parents in a sense. However, in the context of healthy living, it is, one thing to consider is parents still do most of the purchasing of groceries and food and things like that. And kids on average, or adolescents I should say on average, still do eat maybe 5-ish meals with their families in any given week. So there's still a pretty strong potential influence of the family. And then there's just sort of that aggregate kind of family attitude and belief that they've lived in throughout the course of their life. When people look at between group differences though, so if a parent is pretty heavily involved in their weight loss intervention or not as involved in their weight loss intervention, there aren't a lot of group differences in terms of the weight loss. It's not necessarily negative to have the parents involved, but there's just really no difference between the two groups. Looking at some findings a different way when we look at predictors of weight loss for adolescents, or what variables are sort of associated with the adolescent weight loss. Parent weight loss is one of those variables that's pretty strongly associated with the adolescent weight loss, as well as parent self-monitoring. So if they're doing their own food logging and things like that, that was also associated with adolescent loss. So it really does seem that parents do still have an influence even when they're adolescents. So probably still a good idea to have parents on board and involved. The adults is even less clear. The data are fairly limited, but when we look at just the adult literature on this, social support does seem to be helpful for women a bit more than men. So women, if spouses or friends are kind of involved in their behavior change and weight loss goals, that can be helpful, but the same really didn't hold true for men. So as we think about this social support and modeling piece, I think we have to think about how it may play out a little differently for different members of the family. So for some case examples, general social support, like I said, when people are coming into family clinic, they're all kind of on the same page that the people that are there all sort of need to make changes. But some families are just able to really support each other a little bit better while still maintaining good parent-child boundaries. So we have a parent and teen who really got into using like a phone app, the MyFitnessPal, for some of their logging and tracking, and they were able to really share their goals and see if each other are on track in a way that is not preachy and naggy from the parent, but is just really, we're all doing this, and how can we kind of course correct when we fall off this path, and how can we problem solve together? So they really seem to have a team sort of social support piece. This is the same family I mentioned earlier who really did a good job with family planning and thinking about their vacations or other family events, because they do a lot of things. They're a busy family, and they're able to kind of be each other's go-to people for support in some of those more challenging times. Modeling in practice, as you may suspect, is sometimes really great and sometimes a lot more challenging, because all parental behavior is sort of fair game to model, right? And so sometimes parents are really struggling and having a hard time making changes, and the kids see that and pick up on that. So just for kind of a gradient of examples, we have a pretty fun family where there's a school-age boy and his parents come in and they're all pretty on board with, if you give us the information, we'll try to make the change, just sort of tell us what to do. So they've made a lot of food changes together and are pretty literal. So you kind of tell them, like, eat this or don't eat that, or do this or don't do that, which doesn't, as you know, usually happen, but they kind of like that type of information, which is fun. And so they just do those things or try the best that they can. And this boy happened to attend Camp Healthy You this summer, which is a YMCA camp that we help run, and they get pedometers at this camp. And so he went home with his pedometer, and then the next month when we saw them in family clinic, the mom was really hoping to get a pedometer too, so that they could also start doing that together. And just kind of as a side note, they were actually doing Pokemon Go in the park and wanted to track their steps and all of these things. But it's just kind of fun that they really wanted to, mom wants to model these things and do those same changes. So that was a really good example of modeling. Kind of a middle of the road, we have a family who mom and daughter spend a lot of time together. They're the only ones at home. And one of their routines is to watch TV at night and snack in bed together, just kind of like watching things and snacking. And one of their goals had been to really work toward keeping their eating at tables and trying to not have those high-risk times of kind of that mindless eating where you just snack and don't really know what's happening. And they came back to say that they were making some changes, but they were still doing their movies in bed and snacking, which didn't sound like a great modeling. But then kind of with talking to the mom further, she said, well, I just really don't understand this idea of eating at tables because, you know, I'm portioning out our snack. So we just take up like the amount that we're allotted to have, so to speak, and then we have that and then we're done. So in a sense, it was kind of like a middle of the road. They had made some of those changes in terms of portion control, and mom was really trying to teach the daughter about that portion control piece and how they could kind of still do the things they really enjoyed, but in a way that was maybe a little bit more moderated. And then, like I said, there are families that just really struggle. We, a while back, had a family who, a couple kids came in who carry excess weight. Mom also carries excess weight. Mom had significant kind of mental health challenges and depression and a lot of life stressors and really struggled to make the changes. And the preteen patient is a fairly outspoken patient, and she would just basically say, like, well, I know all of the candy's hidden in my mom's room, and she thought she hid it, but it's actually in the closet, and I know those are there, and those types of things. And that's because mom really struggled too, and one of her coping mechanisms was kind of that go-to snacking food, and it was really hard to make that change. So she was struggling herself, but the daughter, you know, struggled with some of those same things and knew where the hiding spots were, so they both really struggled with that kind of still going to those pieces. In the context of that depression, mom really had a hard time seeing how anything was going to be helpful and really couldn't make those changes, talked about that pretty openly in front of everybody. So, you know, the daughter also picks up on that and really struggles to make her own goals and changes as well. So, you know, in practice, sometimes modeling is great, sometimes modeling is not as helpful. All right, and then finally, just kind of touching back on the biology aspect. We already talked about that 40 to 75% of the variance in BMI is genetic. Sometimes in the context of a family, this has worked out sort of interestingly that an intervention approach that we use for one member of a family, we may not have thought of for the other individual had they been there individually, but kind of by way of the family have been able to determine those things. And this is particularly true for kids who maybe have a harder time really describing their experiences, so describing their hunger, satiety types of things, or describing their, I'm constantly thinking about food, or those pieces where parents can maybe provide some of that description a little bit better. And so as an example, we had a teen mom and daughter combo who mom on intake had a baseline BMI of 37. She, from the get-go, first time said, I've lost weight many times over my life. Weight loss is really not a problem. I've got a goal. I can meet it. And she can. But maintenance is just like it's just way too hard. I hit my goal and then I'm done. And the teenage daughter, BMI was 31 at baseline. really struggled. They could identify she struggled a lot with just constant hunger, poor satiety cues, and things like that. They both started out with lifestyle interventions. They made some progress, but then struggled again with maintenance and just kind of variability in their progress. And so Dr. Sibley had started Mom on topiramate. So after a month, she was down 7 pounds. Next month, she's down another 11 pounds. Through this, she's describing her changing experiences, and the daughter's still describing, and Mom is really more so observing that she's still really focused on food, really hungry. The satiety piece just isn't there. And so Dr. Fox, kind of through this discussion, ended up prescribing topiramate for the daughter as well. And then after a month, she's down 6 pounds. And probably the more notable part than the weight loss itself is just their description then on follow-up. The teenager, I should say, is no longer, so hungry. She's not asking about food all the time and wondering about that next food and how much she can have and things like that. So it's just that experience that really changes and allows them to make some of those lifestyle pieces a little bit better. But this teenager in particular is probably one that Claudia may not have gotten there with, because she wasn't as good about describing those experiences without that assistance of her mom kind of having that experience and being able to help her describe that piece. And then just as we're wrapping up, like I said, we've been doing this just over a year. It's a half a day a month, so we're obviously still learning a lot. One thing is just logistics. We had done a lot of forward planning about how do we get all the providers, how do we get all the people on the schedule so everybody can be seen in the morning, that type of thing. Can adult provider be in the discovery clinic? She could. It's awesome. One of the things that I'm not really sure how we overlooked, but we did, was just how much time it takes to room maybe 3 patients instead of 1 patient. So some of those things we've worked out over time. That's fine. They're just logistics of any clinic that you just kind of work out the kinks. I think one of the things with the startup clinic is it's just interesting to really think about that mission. The mission overall is to treat all of these family members who are struggling with obesity. So there's that big mission. But then it's kind of what families do we think are best fits for this type of clinic? Is it the family who everybody's really struggling? So they just all really need intervention from multiple avenues, right? Is it that family? Or is it the family who at the core kind of has some ability to work together on things and has reasonable communication with each other, and so we can sort of maximize that strength to help them with this familial difficulty with obesity? And really, we take who's referred and who's interested in the clinic as in any clinic. But it's one of the things that we kind of struggle with in terms of what families might we suggest to when Claudia or Shalimar are seeing their patients individually. Who is it that maybe is going to benefit the most from this type of approach? As with any team, we need good team communication, especially when we're kind of in all different areas. We're pretty lucky that we have a team that gets along and works well together. And like everybody, you always want more. I'm the only psychologist on the team. Our dietitian, Jessica, is the only dietitian on the team. So we're doing kind of both the peds and adult pieces and the family management pieces. And so, of course, adult behavioral health provider might be nice, or a second dietitian or something. We are finding, as I alluded to in some of the case examples, that the mental health concerns are pretty significant, particularly for some of the adults. And this is not a clinic once a month, half a day, that we're doing real, mental health intervention. We're doing some family management types of things, but we've really been working at trying to get these families the therapeutic support that they need in order to move forward. And then, of course, down the road, we want to see how our outcomes stack up compared to our pediatric and adult clinics and just other programs in general, but we're just too early to have those data to really do those comparisons at this point. So, thank you so much. There's one right here.
Thanks so much, Amy, for that overview. It's all exciting to hear. Would you please explain to us how the clinic visit looks for the family?
Sure.
What you actually do in the clinic, and also The second question related to that is, will, for the most part, insurance companies pay for this visit? Thanks.
Yep. So I guess the insurance question is, I think insurance companies that are going to pay for the individual treatment are going to pay for the family treatment, because it basically ends up from a billing standpoint being each provider bills out their time. Kind of as, at least from my standpoint, I bill the same thing I'd bill whether I saw a kid in pediatric weight management or the family weight management clinic. True, Claudia? Yeah. Okay. From how does the day look, we've, depending on the number of patients and what they need in that given month, they see either all the providers or a subset of the providers. They almost always see Claudia and Shalimar. Well, they pretty much always see all of us, I guess I should say. So we have gone a little bit to scheduling them in like 2 phases, where there's kind of an 8 o'clock arrival time and a 10 o'clock arrival time. And then they actually have individual appointments, 8, 8:30, 9, 9:30 with the different providers. But basically we're cycling through the rooms and moving in and out of maybe 3 treatment rooms that are going, and then kind of the 10 o'clock phase comes and we do the same thing. You look like you have a question.
It was a great talk. How good is follow-up? How likely are families to come back, or is this something that's just, one shot and they give up?
I would say, I'm speaking without actually having the stats on it, it feels like maybe the follow-up's a little bit better, similar to better, I would say. I'm getting nods, so I feel like maybe that's right. Weight management is sort of a notoriously hard follow-up group, but we've probably had like 10 or 12 families, and I would say we still have 8 or 9 really active that are calling back and coming for their follow-up appointments, which I feel like is actually pretty good.
Sometimes treatment intensity is a significant factor, and sometimes we do clinics on a monthly basis because that's when everybody can assemble. One begins to wonder if more frequent visits starting out would be a better methodology, and then maybe titrating those over time.
It's funny that you mentioned that, because just yesterday, it's like you were listening, but you weren't. So, because I wasn't in the same room with you. Claudia and I were just having that conversation. So these behavioral-based intervention programs really go on that model. Weekly weekly sessions, 8 weeks, and then fade out from there. And then tertiary care programs in general see kids monthly, every 6 weeks, and that's kind of their more regular to start out with, and then they might fade from there. And I think as the behavioral health provider, I'm often caught in that struggle between how could we make those two maybe come together, because there certainly is that idea of more intense on the front end might be helpful. We do have it. I have a couple families from the family weight management clinic that actually do come in more regularly for our portion. So they'll come in every 2 weeks, so once a month on the official family weight management clinic, and then in between at least one time to see just our section. So, or maybe they'll see us and our dietitian Jess. So sometimes we'll do that for a family that does really seem like they can't bridge that gap to a month. That is a pretty long time.
Amy, I don't mean to put Alice on the spot here, but you talked about the members of your team, and I know Alice is your nurse coordinator, and she's here. And I also
she's
know
awesome.
I also know it's budget cycle season, so I'm thinking about your needs. Is Alice willing to comment on, does she play a role in the adult or in the family clinic, or is there a plan for development of that role?
The plan for development of that role would be your decision. No, Allison is an integral part of the team. She's there on family weight management clinic days, and I probably say, for however many families we have there that day, I say to every single family, before I let you go, I have to go ask Allison, because she's the keeper of all these details. She does the grid. She really makes all of those pieces of the puzzle work in terms of making sure that as we have all these people lined up, is it actually that all the providers can see them according to who else is there? Is this a month where the kid's not coming, so Claudia doesn't need to see this family this time and all that? So Allison does all the puzzle pieces, puts it together, and then also does all the stuff during the day of, getting in, you need this form, you need this prescription refill, you need to go to labs, let me walk you there. She does all that stuff. So she can't ever leave. Yeah.
So just another logistical question. You have sort of individual appointments with a patient. Is there a team meeting at the end where the team members get together and formulate a plan for the family, and how is that communicated, the comprehensive plan communicated to the family?
Yep. So the latter part we're probably needing a little bit more work on. So how do we communicate our comprehensive plan, like how all of our puzzle pieces fit together to the family? I think we could probably do a little bit better on, and that probably is more my job, and of course I could get better at that. We communicate, I would say, fairly well together in terms of at the end of each family clinic day, we kind of review where we've been, and then which, we start to help Allison put that puzzle piece together. So this family for sure needs to come in again next month, or they could skip a month, or they need to come in actually in between. Who needs what, and what medications are they on, and what are they struggling with, and things like that. During the day, we also pretty much go in and out of rooms and then say, this is what they're struggling with. They went on vacation, so-and-so starting school, all that kind of stuff in the day. So we do an end of clinic meeting there to plan for the next one. And then typically, like I said, rooming kind of takes a long time in the morning because, 3 patients instead of 1 need to be roomed. So we usually have another half hour to review what we had decided at the end of the prior month, so kind of a prepping meeting. But I do think that second portion of then how is that comprehensive plan maybe communicated back to the family is something that could use some work. I mean, families get a little bit stressed out about that it is a long time that they're there, kind of forgetting that I don't know if they're forgetting that they're seeing 4 people, but, kind of forgetting how long 4 appointments truly takes, so.
Amy, thank you.
Yeah.
I want to thank you for
No
a great
problem.
talk about the weight management service. And if others have questions, I invite you to approach the podium. I think Dr. Gross will be here for a few more minutes. Thanks, everybody.
Thanks.